morning. I guess it is still good morning, so thank you so much for having me here. I'm so excited to be here in the UK. I was really honored when Haley invited me to come to England and to give this talk and to be a part of this amazing event. I have to say, before I say anything else, I'm so impressed by the passion and just the dedication of all the speakers and all the people here. And I know there are clinicians in the room and cancer advocates and researchers and general practitioners and cancer doctors, and it's just great to see the passion and the integration and the amount of work that's going into it. I did want to really thank Rachel for all the logistics that you helped with setting up flights and hotels and everything, and I have just a gift for Rachel. Very patriotic American shirt. I have one for Haley too, because she spent a lot of time on the phone with me, and maybe you can give this to her when you get a chance. Thank you. I'd also like to say that I've had a couple of days here in the UK in Northern England before coming here to Sheffield, and so my wife and I have had a chance to travel around to the North Yorkshire Dales and to the city of York, and now here to Sheffield. So it's been a wonderful experience so far. So really thank you for your hospitality. As Will said, I was invited here to give an international perspective, and when I first was invited, I thought Haley wanted me to kind of cover the bases from all over the world and what was happening, and really I think what you really want to hear is what's happening in the United States. So I've focused most of my comments on the United States and what we're dealing with over there, and I hope that it's relevant. I think that in some respects, actually, you're more advanced than we are in terms of the level of integration between the healthcare systems that you have, and I think primarily due to the national health system that you have, and the fragmentation in the United States really does pose significant challenges that we have for different healthcare systems and different hospitals that don't always talk to each other. So I think actually we can learn a lot from each other and hoping to manage some of these issues that cancer survivors are facing. This is Atlanta, Georgia, where I hail from. It's in the southern part of the United States, and that's the American Cancer Society's national home office where I work. So I just wanted to kind of show a picture of where I'm from. This is the mission statement of the American Cancer Society, and we are a nationwide community-based organization dedicated to reducing death from cancer and reducing suffering from cancer through research, education, and advocacy. But we do so many things, and it's so hard to really focus. So one of the things we've done over the past couple of years is identify priority areas. So instead of trying to do all things for all people, which usually is a failure, we've tried to focus our efforts on specific areas. And you can see here, these are the 6 priority areas that the American Cancer Society has identified. And I'm very proud to say that quality of life and survivorship has been called out as one of the 6 primary priority areas of the American Cancer Society, and really leads to some important work in the area that I focus on. What I'd like to do today is to spend some time talking about what is a cancer survivor and really define that definition of a cancer survivor, because I think it is a controversial term. I'd also like to discuss some trends in survivorship statistics that we see that have recently led to the growing population of cancer survivors. I'd like to call attention to some of the physical and emotional side effects that people experience, some of the issues that people experience as a result of their cancer. And then close with raising some challenging questions, some of the things that we're having to face and how we're going to move forward, and then close with future directions in terms of how we see that happening in the future. So again, who is a cancer survivor? And Dot put that so eloquently when she said she may not identify with that term. And it's true that many cancer survivors don't always identify with that term, so I think there is some controversy. Cancer survivors are a very diverse group. 1 in 3 Americans will be diagnosed with cancer during their life. There are over 14 million cancer survivors in the United States, 32 million cancer survivors worldwide. That's about 4% in terms of the US, about 4% of our population of cancer survivors. And we know that this number is going to continue to grow as the population grows overall and as the population ages. And we know that cancer survivors, as Juliet highlighted so nicely, have a unique set of needs in terms of physical, mental, and social functioning. We have so much to learn about providing optimal care in terms of helping them get the services they need, helping improve their health behaviors, and helping improve their overall quality of life. I'm going to show you a definition of cancer survivorship or survivors that we use in the United States, and it was originally established in 1986 by the National Coalition of Cancer Survivors. And it defines a cancer survivor, as a person who has been diagnosed with the cancer. From the point of diagnosis onward, one is a cancer survivor. And that's a good thing because it really empowers cancer survivors, but it also poses challenges because it adds complexity to it. So in the past, historically, before this definition was provided, a person was not considered a cancer survivor until they were 5 years post-diagnosis, 2 years post-diagnosis. After treatment was completed, they were sort of out of the woods. And this definition is much more broad and much more inclusive of people. So that's the complexity. But you can see that you have cancer survivors who are your traditional post-diagnosis, disease-free, off-treatment cancer survivors, what we classically think of as a cancer survivor, someone who's beat the disease. But that also opens the door, this definition, to people who are newly diagnosed in active treatment, in the throes of fighting their disease, are considered cancer survivors. And then you also have people who are living with cancer as a chronic illness. So people who have cancer, treatment works for a while, they have a recurrence, they go back into cancer treatment, and they kind of yo-yo back and forth. And all of those individuals are cancer survivors as post-diagnosis, off-treatment, disease-free. But this is a more general definition. And actually, the National Cancer Institute includes cancer caregivers, the people who are caring for cancer survivors, as cancer survivors themselves. So you can see over the years, the definition has gone from a very specific group of people who are off diagnosis and off treatment, I should say, and disease-free, to inclusive of people who are just in the throes of treatment. So let me turn now to talking about a couple of trends that we see in incidence and prevalence. And I thought maybe we'd just stop for a moment and just maybe not assume that everyone knows what we mean when we throw out the terms incidence and prevalence, and maybe do a little sort of epidemiology 101, if you will, and just kind of define these terms so we're all saying, knowing what we're talking about and saying the same thing. So incidence really is the diagnosis of new cancer. So in a given time frame, for example, in 1 year among a specific population, the number of new cases diagnosed in a year. So a country like the United States might have a very high incidence of cancer, not an incidence rate or just the incident of overall absolute number of cancer survivors, because we have a large population of newly diagnosed individuals. Now we turn to prevalence. Prevalence is the number of people currently living with the disease. This is your more classic definition of cancer survivors. Again, you can compute both a rate and an absolute number. When we talk about prevalence, we're usually talking about the absolute number. When we talk about incidence, we're usually talking about incidence rates. And at the American Cancer Society, we publish every 2 years this document, which is called the Cancer Treatment and Survivorship Facts and Figures. And in it, it provides cancer survivors resources for clinicians, resources for caregivers. I brought stacks of them here for you all to take, and please take a look at that and take it home, and hopefully you can use that in your work going forward. Some of the trends that we see cited in this document, one of the first trends I'll talk about is increasing incidence. And so what we see here is that back in the year 2000 in the United States, about 1.5 million people were diagnosed with cancer. And you can see by the year 2050, 2.5 million will be diagnosed with cancer every year. So on a yearly basis, you can see that the incidence is increasing. And this is primarily due to the growing population. So we have a growing population in the United States. We have more people, and the fastest growing segment of the population is among people over the age of 65. So you've got more people and more people over the age of 65 when cancer tends to be diagnosed, and thus you can see a 100% increase in the prevalence, absolute prevalence over time in the United States, and that is repeated in most Western countries around the world. The second trend is increasing survival rates. And so what we see here is similar to data that Juliet showed that indicated that back in the 1950s, about a third of the people diagnosed with cancer were living 5 years after their original diagnosis. By the 1970s, that number had increased to half, so we were able to see that 50% of the people were living at least 5 or more years after their original diagnosis in the mid-1970s. And now we see that number approaching 2/3 or earlier when they're more treatable, and better health behaviors, compliance with screening recommendations and health behavior recommendations. So if you sort of put those two things together, increasing prevalence, so there's more people being diagnosed with cancer, and you put that together with increasing survival rates, what do you end up with? More cancer survivors. And as you can see, this slide clearly represents the growth in the overall prevalence, 5-year prevalence of cancer survivors over the last 30 some odd years. And it's about a 2 to 3% growth over that time every year. And so now in 2014, we're about 14 million cancer survivors living in the United States. And by the year 2022, that's anticipated to be about 18 million. So again, we can see a growing population of cancer survivors, and the growing needs of that population really need to be attended to. This is not just a problem in the United States, this is a worldwide problem. In fact, we see the largest growth in population in low and middle income countries in those middle-aged people and older individuals, and that's primarily due to actually controlling tuberculosis and other infectious diseases. So more people are living longer in these low to middle income countries, again, when cancer tends to be diagnosed. And you can see here that international prevalence rates sort of correspond to that. We see that since we have the best treatments in the westernized countries, we see the most numbers of survivors in Western countries like the United States, in Europe, Australia, and Canada. So we see the most number of survivors. There's more people being diagnosed in some of these other countries with larger populations like India and China and all over Africa, but they're not living as long because the treatments are not as advanced and they can't get into treatment. So the survival rates are not as high, so you have higher prevalence rates in the westernized countries. And again, just to reiterate the point that the population overall in cancer survivors and overall is growing most in that older age segment when cancer tends to be diagnosed. So let me turn now to some of the issues that cancer survivors really experience as a result of their disease. And it really, as you can see, cuts across almost every major system within the human body, including cardiovascular disease and cardiotoxicity as a result of chemotherapy, bone fractures, increased risk of bone fractures, sexual dysfunction in men and pain in women, menopausal symptoms exacerbated by premature ovarian failure due to chemotherapy-induced menopause. So a number of problems. Chemo brain is another one that's very common, and of course anxiety and depression that have been talked about a lot today. So again, probably could spend 45 minutes just talking about all the problems that cancer survivors have, but this really cuts across the many systems in the body that are affected by cancer. This diagram really represents the model of quality of life that we tend to use. And as you can see, and as was referred to earlier, the major domains include physical, psychological, social, and spiritual well-being. So in the physical domain, things like pain and fatigue and some sexual problems, infertility, for example, fall under the physical domain. In the psychological domain, you see anxiety, depression, and fear of recurrence. Social domain has to do with the family, the impact on family and the changing roles. So someone who was formerly the primary breadwinner now goes into cancer treatment. Other people have to step up and fulfill those roles. So changing roles can really impact the family unit. Things like isolation, physical appearance, affect your social well-being, your ability to interact with others in the way that you formerly did. And spirituality is an interesting component of quality of life in terms of making meaning of the illness. So uncertainty about the future, but also sort of positive aspects of having had cancer in terms of post-traumatic growth or benefit finding. And Lance Armstrong, who's not such a popular figure anymore, but when he was quoted as saying cancer diagnosis was the best thing that ever happened to him. So, stopping to have a new appreciation for life, new meaning in life, and rekindling those important relationships, there are some positive aspects of the cancer diagnosis. I want to make a distinction also between long-term and late effects. And so long-term effects are those types of symptoms that tend to present early when a person is in the throes of diagnosis. You can see things like pain, fatigue, sexual dysfunction. Those sorts of things present early and may stay with the individual for many months and even years in a very chronic, persistent way. And you can differentiate those from late effects, which are those things that might not show up for months or even years. So the cardiotoxicities, the bone fractures and osteoporosis, those sorts of things that 5, 10, 15 years down the road due to the chemotherapy that you received, you have early onset of cardiovascular disease and other types of problems that plague cancer survivors as a result of the treatments that they have received. Symptoms obviously have a huge impact. In terms of ability to complete one's treatment, often people who have intensive symptoms, symptoms can impact people's ability to go back to work, to engage in their usual activities, and obviously symptoms affect people's quality of life. The big three in terms of symptoms, and there are many symptoms that people experience, as you saw from the slides, but the big three are really pain, fatigue, and emotional distress, and these are the ones that are usually the most prevalent and the most distressing. So cancer-related pain is extremely common, extremely prevalent, especially during treatment. Upwards of 80 to 90% of cancer patients during treatment experience pain. It's also the most feared symptom. It's extremely distressing. It's also not well understood because its etiology can be multifactorial. So you can have pain from the disease process itself. You can have pain from the treatments that you receive. So being able to identify the source of pain is very important. Unfortunately, pain is actually often poorly assessed and not well managed, especially in the United States. We don't tend to ask people about pain, so we don't do a good job of assessing it. And then once we do, if we do ask about it, it's often not well managed. The good side of that is we actually do have medications and both pharmacological and non-pharmacological interventions, such as stress management, that can help people cope with pain. And obviously, adequately controlled pain is an important part of quality cancer care. Here you can see some prevalence estimates for pain. So obviously, pain is highest in people who are either in treatment or have chronic disease. But you can see that even among cancer survivors, upwards of more than 30% are reporting ongoing cancer-related pain. Fatigue. And cancer-related fatigue is different than normal fatigue. Normal fatigue is relieved. If normal fatigue is a thing that happens when you work out or you don't get enough sleep, and you get some rest and you feel better. That doesn't happen for cancer survivors. It's not relieved by rest. It's not relieved by many things. So it's a different type of fatigue. It's also multidimensional. So it's not just the general feeling of being tired, but it can express itself through mental fatigue, not being able to concentrate, memory impairments. Kind of general physical fatigue in terms of aches and pains. Fatigue can manifest in emotional ways, especially among people who don't want to somaticize their disease. Can express as depression and other emotional issues, and just inability to get things done. And then I mentioned cognitive problems as well. Unlike pain, we don't really have great interventions for fatigue. So we can talk to people about fatigue. We can teach people to recognize it. There's some hope that exercise interventions do relieve fatigue, but it's not firmly established. So a bit of a quandary there, and the fact that it's one of the most prevalent and most distressing symptoms, yet we really don't have really good interventions for managing cancer-related fatigue. Here again, you see prevalence estimates for fatigue, high numbers for fatigue in newly diagnosed and people up to 2 years, but you still see that even 5 years after, 20% of people are reporting fatigue. So you can see it's a very persistent problem. The third big problem, emotional distress, anxiety, depression, fear of recurrence or cancer-specific worry. Again, you can see 30 to 40% of cancer survivors expressing emotional distress. Again, like pain, fortunately, we have really good treatments, both pharmacological and non-pharmacological interventions for emotional distress. I wanted to spend a moment just focusing on fear of cancer recurrence, because this is really specific to cancer survivors in terms of anxiety. And some level of fear of recurrence is normal. It's an obvious and important reaction to worry about your disease coming back. The problem is when it becomes debilitating, when it starts to negatively impact your ability to function in your normal life. So if you can't go back to the doctor because you're so worried about what the test is going to show, or if you drive past the hospital where you were treated and you break out in a panic attack, that's when fear of recurrence becomes sort of problematic and debilitating. It also is very episodic, so most of the time people are fine. They're not walking around always worried about their cancer coming back, but they're coming up on their annual mammogram, or they see something about cancer on TV, or someone asks them about their disease status, and it triggers heightened anxiety, which can be extremely distressing. Here's some data from the American Cancer Society's studies of cancer survivors, just showing the prevalence of some symptoms associated with fear of recurrence. And you can see across the board there that upwards of 30, 40, even 50% of cancer survivors, regardless of the disease that they had, having high levels of fear of recurrence. And this is interesting because some cancers tend to come back and recur, moderate to severe levels of fear of recurrence. So there's a sort of a general concern among cancer survivors about their cancer coming back. Wanted to highlight, in addition to those big three symptoms, some of the real issues that we're facing. And this report is from the Institute of Medicine Delivering High Quality Cancer Care, and really spoke to some of the challenges that we're facing in the United States in terms of treating cancer patients. You can see a quote here that says, "Cancer care is not patient-centered. Many patients do not receive palliative care to manage their symptoms, and side effects and decisions about their care are not based on scientific evidence." So clearly in the United States, we're not doing a good job of caring for cancer survivors. You can see the numbers here that the high cost of cancer, these speak to the economic burden that cancer causes. Over $125 billion in 2010 spent on cancer care, up from $72 billion in 2004, and that's just expected to continue to rise as the number of cancer survivors continues to grow. The other thing is that cancer, there are a lot of hidden costs with cancer in the United States, uncovered costs. So even just driving to the facility, housing near the facility, prescription medications, loss of wages due to taking time off of work. There are a lot of hidden cancer costs that are not reimbursed or covered by insurance. And this disproportionately affects those of lower socioeconomic status. So this cartoon sort of highlights what some of the problems we have. So it says, it's a gentleman sitting at a bar with a cigarette hanging out of his mouth, smoking a beer, or smoking a cigarette, drinking a beer, eating a burger and fries. He's obviously overweight, asking, can you give me one reason why my health insurance is so high? So clearly we've got important work to do in terms of changing people's health behaviors. The bankruptcy rate is twice as high in cancer survivors than it is in the general population. So what I want, who will care for this growing population of cancer survivors? So I showed you these numbers of the exploding population of cancer survivors in the United States and worldwide. Who is going to take care of all these individuals? And we did some work in our survey where we asked cancer survivors, and these are data also from the studies of cancer survivors. And what we did is we asked cancer survivors to indicate the level of responsibility for their cancer doctor and their primary care doctor or their general practitioner for these things like following up for your most recent cancer, screening for cancers other than your primary cancer, general preventative health, and other medical problems. And they would indicate for each of these doctors whether they thought they should have full responsibility all the way down to none. And what we see here is that cancer survivors had a strong preference in terms of management of their follow-up for their cancer care. About a quarter indicated they want their oncologist to still have primary responsibility for that. But 64% were open to the idea of a shared care model. So if you add those together, you have around 88% of individuals indicating some type of preference for shared care oncology-led model. And only 13% indicating they want their general practitioner to care for their cancer-related follow-up. When we look at cancer screening, the picture is somewhat similar. You have a few more people now starting to indicate they're okay with their primary care doctor or their general practitioner doing that, but still strong preferences for either a shared care model or oncology-led model. When we look at non-cancer related general preventative care, clearly individuals in the United States are fine with their general practitioner. 3/4 of them indicating they're okay with a PCP-led model. And we see the same story when it comes to non-cancer related problems. But one big problem we have in terms of caring for this growing population of cancer survivors is the shortages in healthcare providers that we have in the United States. So you can see here that back in 2005, the supply and the demand were sort of close by each other, so we had enough providers to care for the number of survivors. Here in 2015, that's starting to grow. By the year 2020, there's going to be extreme shortages in the supply of both oncology professionals and non-oncology general practitioners to care for these cancer survivors. So it's really an important question. Who is going to care for this group? Are we going to develop new models? Is cancer rehabilitation going to step up as a specialty care? Is primary care going to take it on? How are they going to do that with the shortages and the healthcare providers that we have in the United States? The second question is how do we identify optimal models of survivorship care that meet the needs of all the cancer survivors that we see? In the United States, as I mentioned, we have a somewhat fragmented system. So the care is really driven by the survivor themselves. So they're going to go to their oncologist, but if they also want to see a psychologist or if they want to go to cardiology, they have to coordinate that. And that poses real challenges for people to understand the system, to navigate the system, to get to the healthcare providers that they need. And there's a lack of communication between these different providers in terms of a multidisciplinary approach, and we really need to do a better job of getting these different providers to talk to each other so that we have holistic care. I mentioned the IOM report at the end there, but there were several other IOM reports that really highlighted important issues. This one in the middle is called From Cancer Patient to Cancer Survivor Lost in Transition. It was mentioned earlier, this is a very distressing period of time. And this last one here talks about cancer care for the whole patient, meaning the psychosocial needs of cancer survivors. So focusing specifically on that middle IOM report, cancer and its treatment obviously has long-term impacts on people's health and well-being. That transition when you're coming off of the oncology team and you're trying to go back to your general practitioner, your primary care doctor in the community can be extremely distressing, very confusing. People get sort of lost in the cracks or lost in transition, and we lose a vital opportunity to really connect the oncology team with the primary care team to have coordinated care. These are the recommendations of this IOM report, and I'll let you just kind of peruse those. This was back in 2006, and many of these recommendations have continued to be challenges in the United States, and we've not made great headway on most of them. One of the ones that I want to feature is this second one, providing a care plan for cancer survivorship. So again, patients completing treatment should be provided with a comprehensive survivorship care plan of what a treatment summary might look like. So at the top you have some specific information about the patient. In the middle you have information about the type of treatments that they received and the risk factors associated with those treatments. And then down here, the specific recommendations, the late effects that they might be at risk for due to the treatments that they received, and the screening recommendations, and then how to contact the oncologist who treated that individual. And this document should be provided, well, it should have provided to the patient at the end of treatment, so it includes comprehensive care that they received. It needs to be effectively transferred from the oncology team to the primary care physician, describing risk factors associated with those treatments, both in terms of long-term and late effects. It needs to provide a specific plan for monitoring for recurrence and for other comorbid conditions, and identify appropriate healthy lifestyle behaviors, and facilitate open communication between the oncologist, the primary care doctor, and the survivor and their caregiver. So one of the things that we should be very careful about is survivorship care plans are not a static document. You don't just fill it out at the end of treatment, give it to the patient and tell them to go off. It's really meant to be a tool for communication, a tool for oncologists and patients and primary care doctors to be on the same page about what type of care this individual needs going forward. There are a number of existing templates for survivorship care plans in the United States. ASCO has a template, Livestrong has a template, there's the Journey Forward Care Plan, Prescription for Living, so there's a number of different templates. Here's what one might look like. This is the Journey Forward Care Plan, the Livestrong Care Plan, so there are just many different templates. And care plans have been recommended by a number of different organizations and entities in the United States, including the IOM report that I just mentioned. ASCO recommends the use of care plans. It's also been recommended now by the Commission on Cancer, which is the American College of Surgeons now is mandating that in order to maintain accreditation as an COC facility by the year 2015, 10% of all patients will have to have received a care plan. By the year 2019, 75% of all patients will have to have received a care plan or you'll lose accreditation. So it's now being mandated by the COC, and about 70% of the hospitals in the United States that treat cancer patients have COC accreditation. So there's a big movement for support of care plans and to see them implemented in clinical practice. So you guys might recognize him. I showed this to my friends in the United States. They're like, who is that guy? I'm like, well, I think they'll get it over there. So anyways, but the point is that, you know, obviously care plans are recommended by all these entities. We've got all these different, you know, templates out there. There's a great need for communication between oncology team and primary care team to facilitate good coordination of care. And everybody thinks it's a great idea, right? Well, not so fast. There's been a lot of evidence, or I should say there's been a lack of evidence actually supporting care plans. So as of this date, there's only been 4 RCTs actually looking at the efficacy of survivorship care plans, and none of them have actually found a positive outcome in terms of impact on communication. There's no evidence that survivorship care plans actually change people's health behavior, so they're not necessarily complying with the recommendations in the care plans around diet, physical activity, screening, keeping up with their recommended surveillance. And there's no evidence that survivorship care plans actually change clinical outcomes, that we catch cancers earlier, or that we are reducing mortality. In fact, there is sort of a pushback now against survivorship care plans. Here's an article published by someone who works with the COC saying we should rethink whether survivorship care plans are something we should do. And care plans are timely to produce. If they're not automated and downloading information in an automated fashion from an electronic health record, someone has to take the time to actually complete the care plan and the treatment summary. It has to be communicated to the individual, and those services and those times in the US are not reimbursable. So they have to take time out of their regular work in which they're seeing patients to complete the care plan and provide it to the patient. So there is a pushback against care plans because right now there's a lack of evidence that they really make a difference. Although we all believe that they're the right thing to do, and intuitively we think we should be giving them, but right now we really don't have the evidence that they make a difference. So what I did was just create a list of sort of 10 recommendations or strategies that I thought that we could try to increase the efficacy of care plans. The point is that yes, a care plan should be delivered to the patient and to the GP at the end of care, but it should be created early. It should be started early. There are issues that cancer survivors need to deal with before they undergo cancer treatment. Things like fertility and fertility preservation. These are issues that need to be addressed before a person begins treatment so they can make decisions about their future. And it needs to be a living document. This is a document that we continue to add to as a person is progressing through their cancer journey, all throughout treatment and at the end. One of the problems with care plans is everybody's using their own care plan in the United States. So there's the Journey Forward, there's the ASCO plan, there are all these different care plans. They're not interoperable. So one care plan that's created at one institution, then the individual goes back to their general practitioner treated at a different institution. They don't talk to each other. So these electronic health records are not talking to each other, and so the care plans are not talking to each other. So it makes just transfer of information challenging. So we really do need to, and the other issue with care plans is how much time it takes to actually go through the medical record, abstract all the information that is necessary to put in a care plan. Usually falls to a clinical research nurse or a certified tumor registrar. Again, that time is not reimbursable. So what we need to do is to build systems that will extract information in an automated fashion in order to make the production of the care plan quicker. Now, it does need to be reviewed by a clinician to make sure you catch the true essence and the flavor of that treatment that individual received, whether it was curative treatment or it was palliative treatment. But in terms of downloading the majority of the information, having an auto-populated tool would facilitate the creation and reduce costs. Also, the care plan really needs to assign tasks clearly. What is the role of the oncologist in terms of following up for specific cancer-related issues? What is the role of the general practitioner? And what is the role of the survivor and their caregiver? So giving clear direction to each of those groups in terms of what their responsibility. Another thing about the care plan, it's not just a piece of paper that you just stick in a folder and put in the medical record and hope someone looks at it. It needs to be delivered to the survivor. Someone needs to sit down with the survivor, go over the care plan, and then communicate that to the primary care physician. So some of the research that has shown that care plans are not effective is limited by the fact that they're not doing a good job of communicating the care plan and giving it to an individual. So if you just hand someone a piece of paper, sure, it's probably not going to change their health behaviors. It's probably not going to change their clinical outcomes. But if we sit down, spend time, go over the care plan with individuals, and then communicate the needs to the primary care physician, my sense is that care plans will be shown to be effective over time. Again, just kind of reiterating the point that it's really meant to be a communication tool. It is a living document. It's something that we want to use to start a conversation. It's not meant to be just something that's looked at one time and then put in a folder. Again, it's meant to be a tool that the primary care physician can use to communicate with the survivor about what they should be doing in terms of their surveillance and communicating back with the oncologist if additional information needs to be collected. So one of the things we can do in the United States using is cancer rehabilitation. In Germany, there are 2 weeks of government-covered inpatient cancer rehabilitation after cancer. So any cancer patient can spend 2 weeks as an inpatient if they choose to in a facility completely covered by the government. In the Netherlands, they're doing a lot of interesting work around research with cancer registries and patient-reported outcomes. Obviously, here in the UK, you have identified chronic disease self-management as an important component of care. You've learned how to triage individuals based on sort of risk assessment and use risk-based care to put individuals who don't need a lot of support into a self-management model versus putting those who need ongoing care into a more acute treatment setting. In the US, we're spending a lot of time in developing guidelines for post-treatment care of cancer survivors. There are not right now firmly established guidelines for primary care docs. So in the United States, primary care physicians really don't always feel confident. There is some data out of the CANCOR study that indicates that primary care physicians do not feel confident. They don't understand the treatments that the individuals receive. They don't understand the risk factors associated with those treatments. And so just educating individuals through survivorship care guidelines is something that we're focusing on in the United States. Obviously, we need to listen to what the patient says. We need to provide more patient-centered care. And what do they want? So what we think they want may not be what they really need. So we might think that, and physicians in the United States tend to focus on clinical outcomes. Have they had a recurrence? What's their disease status? But patients care about quality of life. They care about things, what's their functionality? What's their mobility? Can they do the things that they like to do? They might not care what their long-term prognosis is. They want to know, can I live the life that I want to live? So being patient-centered is really important in terms of providing a good model of care. Coordinating among providers, I've been talking a lot about that in terms of exchanging information. What I've listened to so far today makes me feel like we have a lot to learn from a universal healthcare system where you can actually talk to each other. In the US, it's just so fragmented, it's hard to get providers to actually communicate with each other and ease the burden on cancer patients and their loved ones. Jane and Juliet showed this model. So in some respects, you guys are here, and I'm not sure if that's the tip of the iceberg or off on an island. Either way, we really need to learn how to integrate care and to identify a triage system where we can use self-management to really help direct the care to the patients who need it most and save resources for those patients who need it most, and then let people who don't need it go into a self-management model. This is a little schematic of the cancer care continuum. So if you kind of come over here, these are what we would consider healthy individuals, people who've never had cancer, and we're focused here on prevention, health behaviors, trying to get them to live healthy lifestyles, engage in appropriate cancer screening so that we can catch cancers earlier when they're most treatable. And then at this point, you see the point of diagnosis. So some of these individuals without a history of cancer are going to be diagnosed with cancer. And they come down here and we need to develop a treatment plan. And all of these things here in terms of all the services that we can provide, genetic counseling, sexual health, symptom management, all of these things are things that we need to help people manage. And if they are identified as having specific problems, we can refer to palliative care, to supportive services, and to other specialists. As we come around, we see here, this is where treatment starts. You start building the treatment summary, and you come back up around here to cancer survivorship. Again, coming back to those individuals that need ongoing care, palliative care, supportive services, and specialists monitoring for long-term late effects and managing those diseases. So the third big question is, how can we help cancer survivors and caregivers achieve good quality of life? And I've identified 3 ways to help people achieve optimal quality of life. And the first is to really identify those at-risk cancer survivors. So we need to screen individuals for physical and emotional distress early and often. So we need to monitor how they're doing in terms of their physical and emotional health. And then those that we identify as needing additional help, triage them to the appropriate level of care. So if they don't need a lot of help, you can go into a chronic disease self-management model. More advanced diseases or people with more extreme problems need to go into more acute care. And this needs to be delivered in terms of timely evidence-based interventions. Here's an example of a distress thermometer, and I know you guys have a version of it here that you're using in your care planning process. And again, just asking individuals on a scale of 1 to 10, what's your level of emotional distress? And then what are some of the practical and family and emotional problems that you're experiencing? And this tool is great for screening, identifying people who are at high risk. But one of the issues is if you screen, then you have to be prepared to treat. And so a lot of physicians don't actually want to administer a distress thermometer because if you ask people, you're sort of opening that Pandora's box. And if you identify someone who's extremely emotionally distressed and you don't have resources or the time to deal with those problems, often physicians don't want to ask. So we need to make it very clear, if you're going to ask, you need to have the resources to be able to treat. There's a big movement in North America to make screening the 6th vital sign. So we ask every time someone comes in for an appointment, we always ask about blood pressure and even things like pain. But adding distress as a measure that we administer every single time an individual comes in, there's a big movement towards that, and that will allow us to hopefully monitor trends in emotional distress over time, because we really don't have a surveillance system for emotional distress in the United States. We can measure incidence and mortality. We've got SEER data. Every year we can look at the numbers as they change in terms of how many people are diagnosed, how many people died of cancer, and we can look at trends over time. We can't do that in quality of life. We can't do that in terms of emotional functioning, because there is no national database that every year collects nationwide data on the quality of life of cancer survivors. So we need to build those types of things into the system. Here's an example of a triage for appropriate care that I borrowed from our friends down under. So Jeff Dunn and his group developed this triage system where those individuals with only mild distress get kind of general universal care. People with mild to moderate distress get low intensity care, so interventions that are easy to administer and cost effective. And then you get into the individuals of moderate and severe distress going into higher levels of intense care that's more expensive and requires more resources. And the second way to increase quality of life is to focus on prevention. So we know that cancer survivors are at increased risk for comorbidities and other health problems. We know that a healthy lifestyle can help alleviate some of those comorbid conditions, can help prevent some of those comorbid conditions, can help with mental and physical functioning. And so a number of organizations have recommended physical activity guidelines and lifestyle guidelines for cancer survivors that we have tried to implement. They do not include eating at the Heart Attack Grill. Apparently this is a real restaurant in the United States. The waitresses are dressed like nurses. We don't recommend eating their double, triple, quadruple bypass burger. So the American Cancer Society has developed physical activity and nutrition guidelines for cancer survivors with specific recommendations around how much physical activity and what type of diet people should eat after cancer. But it really begs the question, are cancer survivors living healthier lives? There's been the whole movement towards the cancer diagnosis and survival as the teachable moment, as that opportunity, that clinical opportunity for us to, you're heading down a bad path. So a lot of people have put that forth as a really good clinical opportunity to intervene and try to get people to change their health behavior. So are cancer survivors living healthier lifestyles? Well, these are also data from the ACS studies of cancer survivors. And what you see here is a sort of a good news, bad news story. You see that most cancer survivors are complying with the recommendation not to smoke, regardless of the 6 cancers that are measured in this study. Upwards of 80 to 90% are not smoking. That's the good news. The bad news is that less than half are meeting the physical activity recommendation, and less than 20% across the 6 cancers included in this study are meeting the dietary recommendations to eat 5 fruits and vegetables a day. So clearly, we're not doing a great job, and that cancer, and these numbers are not that much different from the general population. So it doesn't appear to be that cancer survivors are actually living any differently than the general population, despite the fact that they've had cancer, they've had this life event that really could have been a catalyst for behavior change. Looking at some of the same data, so what I've done here is that same data that you saw on the last slide, I've taken individuals, and those individuals that met one of the recommendations, none of the recommendations are here. Those who met the recommendation to not smoke but did not meet the recommendations around diet and physical activity are here, and those who met 2 of the recommendations are here, and those who met all 3 recommendations in terms of diet, physical activity, and smoking are here. And what you can see there are these scores represent their quality of life scores. And clearly there's a cumulative effect, where those who meet none of the recommendations have the lowest quality of life, those who meet all 3 of the recommendations have the highest quality of life, and those who meet 2 or more of the recommendations have quality of life that is at or higher than the population mean. So clearly physical activity and meeting health behavior recommendations not only affects physical health, but it can also affect overall quality of life and mental functioning. So there are obvious implications for interventions based on these data. And the third recommendation in terms of how to achieve high quality of life is to actually just listen to the cancer survivors. One of the things that what I think we need to do is sort of integrate patient-reported outcomes into electronic health records and into clinical practice. So I mentioned distress being the 6th vital sign. We need to get patient-reported outcomes into the electronic health records so that people can monitor that over time and can sort of hear what the patients are telling us in terms of their distress. Right now, a doctor may or may not put something in the medical record, and it may not go into an electronic health record. But if we can ask patients about their mental functioning, their emotional functioning, and get that into an electronic health record, we can do a better job of addressing those issues. The other thing is really is really focusing on what sort of a dissemination and implementation science model. So we have interventions, some work, some do not. But we also know that interventions are not a one-size-fits-all. Not every intervention is going to work for every individual. So we really need to understand when we deliver interventions, we need to study what type of interventions do specific groups want and what will work. So what works for whom, under what conditions, delivered via what channels, and provided when in the continuum, and why do these work? So some individuals may want written materials. Older individuals still want paper, hard copy things sent to them in the mail. People who are more internet savvy, younger generations, may be fine with electronic media. So we need to understand, there's different ways of communicating based on race and ethnic backgrounds, age, cultural factors, and we need to understand how do we target those individuals who are most at risk, and then tailor the messages to the needs and preferences of those groups to ensure that those interventions are most effective. So here's an example of incorporating PROs into clinical practice. So again, patient-reported outcomes. The patient is asked to fill out a treatment-specific questionnaire that asks about symptoms and problems when they come in for a clinical visit. That information is then communicated to the care team via charts. So before the patient comes in to see the physician on the next visit, the physician can look at their functioning in terms of physical, mental, and other functioning domains that would be relevant to that specific disease. When they come in, they can go over those things with the individual in real time. Nurse practitioners or physicians can go over that with the individual and then put that information into the care plan. So again, incorporating PROs into the care plan is an important component. So there's also a big movement in terms of patient-centered care in the United States, so really listening to the patients. This quote said that regardless of what we think, patient care isn't excellent unless the patient thinks it is. So again, what we think is excellent care may not be as important to the patient. The Patient-Centered Outcomes Research Institute is funded by the US government. It's a large new effort, and all of the grants have to have a patient-centered component. Every grant has to include a stakeholder group of survivors. It's not just for cancer, it's for all chronic diseases. But they need to include patients in the grant review process, in the grant design process, and so all the grants are considered patient-centered. And that's a big movement in the United States towards patient-centered care. I mentioned implementation science, dissemination, implementation science. Again, this is really identifying, it's really the process of studying delivery of interventions. So typically when we look at interventions and we do evaluations, we look at outcomes in terms of, at the end of the day, did the intervention achieve what we hope that it can achieve? But studying the process of delivering interventions, how best to deliver it, what delivery channel, what medium works best for whom. Again, that whole dissemination implementation science is a big emerging area in the American Cancer Society and in America in general. Obviously, there are lots of organizations, Macmillan, one of them, but in the United States, we have a number of organizations that provide services to cancer survivors. At the American Cancer Society, and I work in the research department, so we really try to integrate what we've discovered in the research department and have that implemented through our programs and services. So what we see here is in the research department, we focus on really discovery and knowledge gain, but then we work together with the sort of applied arm of the organization, which is called Cancer Control. That's sort of the patient-facing, forward-facing arm of the organization that delivers the programs. So they help us work together with us to use the research that we've developed, the knowledge that we've developed from the research to develop interventions. Then they deliver those interventions both at the national level and in our community settings. And then that leads to policy and advocacy efforts that can be used to advocate for the needs of cancer survivors. At the ACS, we have a number of different types of programs and services. We have a call center. It's a hotline that anyone can call 24 hours a day. This is online chat. We also have freestanding brick and mortar buildings. This is a picture of a Hope Lodge where we provide free housing to individuals when they need to get treated somewhere far from where they live. And then we have programs that are specific to individual populations. One of the things that we've been working on most recently in our survivorship is the National Survivorship. Cancer highlighted in red over here are patient-centered tools. And so there's a life after treatment guide. There's online content. There's a chronic disease self-management program that we're piloting. These resources down here are really for providers. And I'd like to focus on the last two, the e-learning series and survivorship care guidelines. So the e-learning series is a web-based psychoeducational tool for primary care docs to teach them about the issues that post-treatment cancer survivors are experiencing or may experience, and sort of educate them and get them up to speed in terms of caring for cancer survivors, increase their knowledge, increase their self-efficacy and their competence. So this includes a pre and post evaluation of their self-rated competence and knowledge. It's been very popular, so it also includes CMEs, or continuing education units for providers, which are required in the United States to maintain their license. So it's been very high uptake among providers in the US. The other thing that we're doing for providers is, as I mentioned earlier, developing survivorship care guidelines. And so we're publishing a series. This is the first article that sort of just gave an overview of the survivorship care guidelines, again, directed at primary care or general practitioners in the United States. Then we're going to publish a series of them. This is the prostate cancer guidelines. And following the prostate cancer guidelines, which were published last year, we're now working on guidelines for colorectal cancer, breast cancer, head and neck cancer, and gynecological cancers. So you'll start to see those come out in the near future. And if you want to learn more about the Resource Center, that's the website. And I've mentioned several times the triage for appropriate care. And I think in the UK, you clearly have a head start on this that compared to the United States. We really need to understand risk stratification, identifying those at-risk individuals and providing appropriate care. Providing risk-based care is where one of the directions we need to head. We need to identify optimal models of everything and navigate the healthcare system. And we really don't have a system in place right now. We've got a shortage of oncologists. We've got a shortage of primary care physicians. We've got a shortage of healthcare providers in general. So what is that optimal model that's going to care for the cancer survivors? Are they going to stay with the oncologist? That's not going to be possible, because the oncology system is going to be quickly overrun by the growing number of cancer people being diagnosed with cancer. Primary care also has a shortage, so that system's going to be overrun. So are we going to develop new specialty areas? There's a big movement in the United States for cancer rehabilitation to be the go-to model for care for cancer survivors. However, cancer rehabilitation primarily focuses on physical aspects and doesn't really attend to psychological aspects as much. So physiatrists and those types of individuals really focusing on lymphedema and physical effects. So that may not be a viable model. Or some new specialty area going to emerge. We've got a new movement for survivorship care clinics in the United States, where they're dedicated clinics for people who are off treatment, disease-free, and to manage the long-term late effects that they may experience. But right now, we don't have the answer. Again, focusing on dissemination of evidence-based interventions. I've harped on this term, in terms of what works for whom, under what conditions. Again, we really need to understand how to deliver those interventions in the appropriate way. There's also great opportunities for use of e-health technology in survivorship care. I think 70% of the US population now has a smartphone or internet access and tablets, so we can really start to move towards real-time interventions. Again, not going to be right for all people, but for a large segment of the population, I think that's one of the directions that we want to head. I just want to close by showing this article, and I recommend everyone take a look at this article if you get a chance. This is the ASCO clinical statement on achieving high-quality cancer survivorship care. It was just published this past year, and it included a number of recommendations, and it really highlights some of the things that I've talked about today in terms of what do we need to do to improve care for cancer survivors in the United States. And so you can see clinical guidance for care of cancer survivors and developing guidelines. Again, primary care docs in the United States are not well equipped to deal with the post-treatment issues that cancer survivors are experiencing. And the survivorship care plans are not necessarily communicating the information that we need to. We need to develop new models of care that are really going to be able to take care of this growing population, and assuring high-quality survivorship care, again, through COC standards. We need to do some better provider education. So one idea is to actually include some training for individuals as they're going through medical school and talk to them about post-treatment survivorship issues. Right now, that's really not a component of medical training in the United States, but building in survivorship care for medical students at that level may improve survivorship care going forward. Obviously, we need to continue to educate survivors and their families and focus on research and policy advocacy efforts. So I just want to close with a quote from my colleague in the United States, Julia Rowland. who said that being disease-free does not mean being free of your disease. So clearly, you can be off treatment, you can be sort of out of the woods, but this disease stays with you for your life. You're always a cancer survivor. You're always going to have that in the back of your mind. And so you're never completely free of the disease, even though you might be disease-free and asymptomatic. I'll stop there. Thank you.